almost 500 applicants for 2 spots.
All right, I will give you the.
But everybody applies to YouTube. I mean, guess what? Those 2 spots already had to. Those are the programs that are nice. She likes an each candidate at 1,000. Sorry. And then also investigate. You see that everyone in the program was an outside candidate. Was an inside candidate in-house. I don't want to waste your time.
What of your program?
What's your link? What's the?
How many did they take?
Sure.
How you doing? Oh! I saw your wife, I just told her, I said, now I see you guys everywhere now.
Good. Then a few other people might come up. And then talk to Raisa.
What's your company's name?
Sure.
The company name itself?
It shows my media studio. It shows my media studio. Yeah, we get it.
Thank you very much.
I was just sending you the link.
Oh, no, I'm not.
Who else do I get?
I can give you the.
I tried to
I'll give you his number.
I just started to know what you mean. All the
Film everything during the session.
Okay, yeah.
Then at the night time, during the awards.
Oh, woo! That'd be hard. I know, now I keep getting touched too. I got labels and I've been like almost a year now.
Congratulations, sir.
I'm not doing anything. I was doing software development. Yeah. Software development, like Indian, AI, and all that. No, thank you.
Not the CFO and right now. Yeah. Most of the VP. That's Citibank. Do you have a number? No. Yeah, I have your number now. So I'll take it to you. It was just interview when I asked you. All right, boss. Thank you again.
Sending my own bills. Yes.
gave me the link and I thought I should. What did he do? Did he text it to me or email it to me?
Let me see. I think I have the number. Let me see. Oh, you not the WhatsApp? Okay. Let me copy the number. I'll send it to you right now. Good.
There it is. That's it?
Yeah.
I can send that to him.
Yes.
Hey, thanks. That works. I didn't know you knew Mal. I mean, you guys.
Oh, yeah,
you guys in a lot to say.
That's right.
Oh, I did. Oh, yeah.
You're not going to want to get it.
And your programs are also in your conference agenda. So welcome back, and we are excited to start the afternoon session with a very, very different and insightful approach. I'm so excited that we can have one of our own who deals in a different realm talk to us today, and so it is my pleasure. It's my pleasure to introduce Dr. Chessie Boma-Awu. She's a clinical laboratory director and the founder of Labs 2 Doctors. In both of these roles, she transforms complex laboratory diagnostics into clarity for clinicians, caregivers, and families. Every result carries more than just data, it carries a patient story. This session will explore how a deeper understanding of that story, grounded in both rigorous science and genuine compassion, can elevate the quality and equity of care that we deliver. Attendees will examine the critical role of collaboration between clinicians and the lab, and how strengthening that partnership is to be more informed. As you can imagine, this is very day-to-day practical for all of us in this room. Communication sits at the heart of this work, and so when results are conveyed with clarity and care, patient trust deepens and clinical confidence grows. Ultimately, this talk challenges us to hold both the science and the humanity of diagnostics together, because when we do, we don't just report results, we transform outcomes. And so, super excited to hear from Dr. Boma-Awu, and so grateful to her for being here to talk about this to us. Without further ado, I'll hand it over to her.
Hello everyone, thank you for the very kind introduction. I'm so happy to be in front of you guys today. And I also want to thank each of you for the wonderful work you do out there every day. I've also been a patient once, and I know what it feels to be in front of a clinician. But today I'm going to be talking as a leader in the laboratory space. The title of my presentation is From Insight to Impact, Bridging the Lab Clinic Gap for Safer Care. I'm going to disclose a roadmap of our presentation today. I'm going to present first sources of errors in lab results, overlap in lab-related roles among clinical care teams, then a case study, patients, animals, and antibody-based assays. Like when your patient is a veterinarian, or when your patient has a pet dog or a pet cat, those things have a role to play with lab results. Some considerations when ordering tests for infectious diseases, consequences of these errors, and last but not the least, lab results are the patient's voice. When the patient cannot talk, that result that leaves the lab is speaking for the patient. And I believe that clinicians and the lab have a common goal. We want accurate results that will produce effective solutions. So I'm going to begin with the pre-analytical phase of testing. When it comes to laboratory testing, there are three major phases. There's the pre-analytical, analytical, and post-analytical. In the pre-analytical phase, this is before the sample ever arrives at the lab. Everything that happens, determining which tests are needed, explain the test purpose or prep to the patient, patient identification, specimen collection, specimen labeling, specimen packaging and transport. In the table in front of you, you're going to see clinicians, nurse practitioners, physician assistants, registered nurses, LPNs, and phlebotomists. Each time you see a check mark, it means that this person is capable of providing this role, and based on the practice, they may be providing that, they may be responsible for that step. Either, for example, you have a clinician, nurse practitioner, and the PA determining which tests are needed. And they also explain the test purpose prep. But you also realize that it's not only the clinician, the nurse practitioner, and the PA who are capable of explaining that test, the purpose of the test to the patient, or preparing the patient. It turns out that the registered nurse, the LPN, and the phlebotomist do this. All of these people have different levels of education. So sometimes I wonder how we calibrate it to enable the phlebotomist prepare the patient, or tell the patient the right way to be prepared for a test. It's known that this phase of testing contributes to 60 to 70% of the medical misdiagnosis as related to lab results, the pre-analytical phase of testing. We're going to look at some of those errors. So when you think about preparing a patient, if you are the patient and the doctor says you need to go to lab court to do blood work, I don't know if we tell the patients, you don't need to jog, don't go running, don't do any intense exercise. You can, keep your prescription medications away if you really have to, if you can do away with them for the next 8 hours. Or the over-the-counter medications, recreational drugs, cocaine. Some people take these things for therapeutic purposes, but it tends to affect the assays that we run in the lab. Herbs, spices, and when I say herbs, even like the green tea, there's a lot of things that I think patients do not really tell clinicians. And I don't even know what the intake form looks like. Like if you could ask your patient, sometimes they probably don't even know what to say, but they will do their best to tell you something. And some of them probably keep some information away from you. But then this goes to affect the results that we release from the lab. Spices, when I talk about spices like ginger and garlic, ginger is capable of increasing your INR and affecting bleeding, and garlic, and other things that we eat that we take from the kitchen. And how soon, how far away from that sample collection should you be indulging in these routine things that you will be taking? Alcohol, fruits. All of this go to affect the test results. As we go on, I'll show you some examples. When they affect the test results, one of the ways they can do it is by the test method. Some of them interfere with the test method. As we go on, you'll realize that there could be one test, let's say hemoglobin A1C. There are 7 different vendors. There are different manufacturers of hemoglobin A1C. Each of them has the proprietary way they design that test. And your patient may be doing something that will be affected by one and not the other. And let's say your practice is just used to using LabCorp or any other lab. Your patient may not be the right candidate for that lab just because of what they indulge in. And it's important that we know the right methods that work for our patients. The other thing that interferes is the instrument method. When I talk about instrument method here, some clinicians have point-of-care testing in their practices. If you do not apply the sample at the right time, if you do not apply the right amount of sample, if the patient wasn't prepared right, that instrument, the results are only as good as the patient prep or the sample prep. So it's very important. Like I showed you, it's interesting that the phlebotomist can prepare a patient, can tell the patient what the test is for, just like a clinician. So even when we hire people in our practices, the question is, are they equally qualified? Have they had the right training? Are they representing my practice the right way? Because the phlebotomists, as far as I know, they will collect the law. But how they prepare that patient for C-reactive protein or for CBC is something I don't know they're capable of doing. But it shows that they're doing in some practices. The other one that I know that you guys are not very familiar with, back then when I was a medtech student, I remember sometime FDA said that the test method or the limitations of different tests should be put on lab results, or they should be communicated to clinicians. Fast forward, I don't remember seeing any lab. I see reports, but I don't see limitations in it. I don't see the test method in it. And when you look at the requisition doesn't carry any test method. So I feel like there's a gap between what the lab is doing and what the clinicians are doing. So this is an example here in front of you. This is a typical package insert from a manufacturer's assay for cholesterol. Right there it says the limitations. N-acetyl L-cysteine at therapeutically achieved concentrations may cause falsely low results. Do this even come across with the results when they come to the clinicians? They don't go out. I've seen a lot of reports I've seen, I don't even see it there. So how is the lab supposed to communicate with you guys so that when you see the results, you have the whole story? That's where I think there is a bridge. Because when that result comes, in as much as you do not 100% rely on this result, you make major life-changing decisions based on this result. Most of the things that shape these results happen before the results come to you. This is just an example. Every package insert has a limitation. Some of the studies have been done. Prior to this presentation, I did a little research with my colleagues who are clinicians. I asked them where they go to get information when they meet discordant or inconsistent results. And I went to each of those places. Some people told me YouTube, Google, micromedex.com, drugs.com. I had every kind of thing. But when I went there, the information we have in the lab is not located in those places. And as a lab director, I will tell you that if you call the lab to ask a question, you may hardly ever get me. Except you insist that you want the doctorate level director. Because somebody in the lab will talk to you and they don't have the information that I have to give you. So I think communication between the clinicians and the lab is very, very important. This is one of those examples. Every test is not created equal. So this is HIV-1 test. And right in that circle there are the different medications that your HIV patient may be taking. And then you have manufacturer A has designed a test that targets the GAG region and the LTR region of the HIV RNA. Manufacturer 2 or B designs another test that targets the 4 region and the LTR. And then manufacturer 3 designs a test that targets only the 4 region. When you order this test, do you really know what you're ordering? I really feel there's a gap. You know, I've always had this in my mind, and I'm happy to be here today to tell you guys that I think we need to refine the way that clinicians communicate with the lab so they can get every information that will guide them in making these decisions. Because you can have a false negative result just because the test has a lower sensitivity for the poor region, which is the drug target. Now we go into the analytical phase. You realize that the analytical phase is full of dashes. In this phase, that's when we operate the lab analyzers and when we perform lab testing. According to the data, it says that typically you will not have clinicians, nurse practitioners, physician assistants, registered nurses taking role in any of this. Who can guess the error rate in the analytical? Just tell me greater than 20, greater than 30. Can anybody guess in this phase? None of you are involved with the results here, in the process that takes place in the lab. Who can guess what is the error rate? What? And you know, in the AI days, I mean, I basically walk into the lab and the lab is running. Like, I don't have to. You think that the lab director is carrying the instruments on their head? No. And you think the techs are working so hard? No, they are pushing the buttons and making sure the reagents are there and the QC is okay and the instrument is ready to go. And when the instrument needs something, it's going to turn yellow light, like the traffic sign, and they will just go there and check and put it, and the instruments are running. So you can imagine how the lab is almost on autopilot. So, and for the most part, these errors that even happen is either poor training or high turnover rate with technicians, as is the situation that we're facing right now, because medtech schools are no longer existing. A lot of them are closed. So we are having to deal with the biology degree and chemistry degree individuals who do not have that background that we had when we got into the field. So it's so difficult to train them, and just when they're learning, they leave. So you have to train somebody else, and when those errors are in there. So we're going to go to the next. This is the post-analytical phase. That is after the sample is tested and the results are obtained. So what are the steps here? Review the results, interpret the results, notify patients of results, adjust care plan based on the results. You realize the clinician, nurse practitioner, physician assistant are the people who are commonly responsible for these roles. Who can tell me the error rate? It's already on the board, maybe. Tell me, is it greater than 30? Less than 30?
30%.
So this. I can only imagine that if the pre-analytical phase has so many errors, when the results have come out and they are erroneous, there's no way that this will be any lesser than this. You are now dealing with wrong results. How can this percentage be better? So I think this is just carryover from the pre-analytical phase. And we've published a lot about these errors, but we are not really standing out to talk with the people, the main stakeholders. And that's why I'm here today. I want to thank Dr. T for giving me this opportunity to be here, because I've been looking forward to talking to my colleagues, all of you who are sitting in here, that I believe that if we stop just publishing and meet the clinicians and tell them where we need help to increase the standard of quality for lab results, then we are automatically taking care of our patients. There is overlap in lab-related roles among clinical care teams. Like you may have seen, every green check mark means that they all perform that role. When you see an X, it means that person doesn't do it. So like the first one says, the patient history and physical exam is only a phlebotomist who doesn't do this. Otherwise, the clinician, PA, nurse practitioner, RN, RPN, they all do it. Sometimes we start our practices based on, I know that as much as we are into clinical care, it's also business. So you want to strike a balance between making the money and taking care of your patients. And this may mean that instead of hiring an RN, you will hire an RPN to do that task. But is the RPN equally educated, equally trained to deliver the results? That's one thing that we really want to ask ourselves. That let them be exposed to the right continuing education content that will keep them abreast with what is going on in the lab, so that they are doing the right thing every time. So here's one case study I just put into the presentation. And this is one of the, this is a patient who was so frustrated that she had to come to lab to doctors. So it's a 55-year-old female with normal BMI presented for pre-operative clearance. She had cataract and they had to do some surgery to restore her vision. And the surgeon told her that they were going to be able to do it if only her A1C results were down. For 6 months, they couldn't get the A1C results down. Normally, they should do A1C testing every 3 months, but they did the A1C testing every 2 months here because she was so desperate that she wanted them to check it every time. And every time they did it at the same lab, and they got the same results. So when you start questioning this result, just ask to go to a different lab because there's a higher chance that you're using a different method. Because otherwise you would be reproducing the same error and you just have to believe it because guess what, they reproduced it, right? So she had 13, the lowest result was 13.2%. And the highest was 13.6 during the 3 times she tested in this 6-month period. And in her frustration, because they had taken her driving privileges, she went online looking, because she couldn't drive again with the cataract, they took it away from her. She went online looking and came across lab to doctors and where you have laboratory professionals like myself. And when she contacted them, we typically look at the results and ask for your supplements, everything that I showed you on that list, they would ask you all the questions that we need to ask as related to the test question that's in front of us. And it turned out that she was taking a lot of vitamin C. She was taking a lot of vitamin C. Not only that, she was taking a lot of turmeric too. Turmeric has vitamin C, but not as much as the vitamin C itself. So what did we do? We decided to stop, we told her to stop the turmeric and vitamin C for 3 days and go back to get retested. After 3 days of not taking those supplements, the A1C was 7.2%. Wow. Went back to the same place where she was tested. She finally had a surgery because she was able to get these results this way. But the clinician wasn't happy that she went looking for somebody else and fired her. So then, this is not the only case that's there. So this is not the only case that vitamin C affects. I decided to put some more here. You have glucose, total cholesterol, triglyceride, uric acid. You realize that there are also specific methods that are affected. So we have to, I'm going to talk a lot about method today because it's so important. Because it wasn't about if she went elsewhere, she probably would have gotten the right results. But she had to use the lab that her clinician uses. So that's why she stuck to the same place and kept on reproducing the wrong result. So you realize for glucose, and there are different methods for glucose. This is the glucose oxidase that is affected by vitamin C. If you take vitamin C greater than 500 milligrams per day, it would affect that acid. So when you need your patient to have this test done, if you don't know the method, to be on the safe side, just tell them to keep some of this, I just call them extracurricular supplements. Because they just want to take them, and sometimes it's not making a change. And some patients have more than one clinician. So this doctor is prescribing here, the other one is prescribing there. They don't even know that this person is, and they're not even telling the doctor. Sometimes some patients come to the clinician, it looks like a challenge. Like I want to prove to them that I got it right, you're not giving me the right thing. Not knowing that you're killing yourself, because that information you're withholding is what the clinician needs to help you. So this score will be low because of vitamin C. Meanwhile, creatinine will be high because of vitamin C, based on the calculation that is used in the assay. Of course, the fecal or quick blood, this is a no-no, because you miss GI bleeding. So what is the takeaway from this? You want to do supplement reconciliation with your patients. I know you already do it. Again, I don't even know if I should be talking to the patients or the clinicians. Because it's only what they tell you that you are able to act on. I don't know how else you should be asking your patients for them to tell you what they don't know that they should be telling you. But I think it's very important that we should get all of this information. Spices, everything you name it, they should just tell you what they did, what they normally do, so you can say, please, can you hold on to this for the test? The next thing is the specimen timing. Again, the timing to sample collection. If you know this, you'll be able to tell them for 24 hours you can hold on to this. Like we helped that patient stay away from this for 3 days, and she was able to get her surgery. And the method selection. Again, I'm sure that the clinicians who work in hospital settings, like teaching hospitals, have access to this method selection, because during my residency days, I know we took a lot of course, and I'm thinking that they have access to it. If you don't have access, they should make this available to you, like some table that says, this method is affected by this method is, and just make it available to the clinicians. When those results come, they can compare against that chart and be able to know where they're heading to. And the fecal occult blood, of course, again, is affected by vitamin C. Look for an alternative. If one test is a problem, look for a different method that will solve the problem. The patient education. Sometimes we really need to educate these patients. I don't know, I know there are different levels, but there's a way, if you cannot educate the patient, you can educate the caregiver. Just look for somebody around that patient to educate, to make it better. And last but not the least, the lab clinician communication. To me, this is so important. I cannot overstate it, that we should, I think if you call the lab, just ask to, because there's also a lab director who has a bachelor's degree. If you just say you want to talk to the lab director, they will give you that person, but that person is not like me. That person has not gone through the education I went through. So they may not answer your questions thoroughly. And just ask you want to talk to the clinician, to the doctorate level lab director, to be able to get the answers that you need. Next, patients, animals, and antibody-based assays. Some of us here probably have pets, but we don't know what those pets do with antibody-based assays. Whether it's serology or immunoassay, they are all antibody-based assays. So I put a few of them here that we commonly see in the lab. So there's the interference type. So if it's like anti-mouse, or anti-goat, or anti-rabbit. And this is not like there's a mouse in your house, so you're going to have antibodies. No. Maybe you're doing some kind of research with mouse. That is the kind of interaction you're having with the mouse. So, or the goat, it's not because you have a goat in the backyard that you have antibodies. No. Again, how do you interact with that goat? Some people kiss the goat. So these are some of the things that bring different things into the lab result. And the rabbit, the same thing. Some people will sleep with the rabbit. So it depends on how you interact with this pet. But I want to tell you that they would either cause the results to be falsely high or falsely low. This is an example here for a falsely high result. This is anti-mouse. When the patient has anti-mouse antibodies, it's going to create that breach. Every time there's a breach, there's a falsely high result. This is an example of when there's no breach. When the antibody is there and it prevents that reaction from going through, it's going to cause falsely low results. That's why you notice that the star is not shining. That's a falsely low result. That's a blocking effect. We have the bridging effect and the blocking effect. When you're collecting this information, please let the patients tell you if they are playing with their rats or their cats or their dogs. So now, what do you consider when ordering tests for suspected infectious diseases? I threw this in because, again, I think some of the most troublesome assays we have in the lab have to do with antibodies. So when you order, let's say you were ordering for maybe syphilis, again, the requisition doesn't tell you the test method. It doesn't tell you the test method. You just know you're going to check their syphilis, and we come to the lab and we get the right sample that was requested and we order. But it turns out that the different tests are associated with methods that have limitations. Like, when do you use the method? I'll give you an example here. So for, let's say, PCR, let me get this one. Okay, immunoblot. It's a serology method, which is based on antibodies. And it says that when to use, features, recombinant antigens and multiple species. But then when you look at the very first one, IFA, ELISA is used a lot, especially for rheumatology clinics. I know because I have a rheumatology doctor that I help them with their lab. They use ELISA. it says that ELISA assays they target single species. And when do you have to use this? It says it's not recommended. Why? Because at the accuracy level, there's false negatives and false positives, a lot of them. So that's why labs that have ELISAs, the results do not just go smoothly. When the results come out, you need somebody like myself to review the results and get the story behind the sample. And sometimes again, if you're too hungry, you may say that it was false negative. It doesn't have to do with it. But not all these tests are not created equal. Sometimes having an insight of the limitations, the level of accuracy, I think it would, just have it on the side like a cheat sheet, it may help you to troubleshoot these results better. Instead of just telling the patients, let's do another test. Go for another blood draw. And they're going to the same lab, the same instrument, the same method, and producing the same wrong results. Consequences of decision errors. So there will be misdiagnosis, delayed diagnosis and treatment, inappropriate and harmful treatment, unnecessary treatment, impact on quality of life, increased mortality, unnecessary procedures and retesting, extended hospital stays and higher costs, and loss of patient trust. Do you know that in healthcare, laboratory medicine contributes only to 5% of the cost of healthcare? It is this cheap, but the errors are so many. So I think that if we just do our due diligence, it will help us to do these tests once and be able to go forward with the business of taking care of the patients. So lab results are the patient's voice. Why? It says 70% of all medical decisions are influenced by laboratory results. This is according to a statement, the joint statement from FDA and CMS. And it also says that approximately 14 billion of lab tests are performed annually in the US alone. That's a lot of lab tests. And I can only imagine the number of tests that I just repeated, this 14 billion. I'm sure a lot of them are just retests. And it also says that 3 to 5% of results contain clinically significant errors. And last but not the least, 30% of adverse events linked to diagnostic errors involve lab data. And I know that we can all, we all have a role to play in reducing this number. I think I've just moved from us publishing to actually meeting the real people to see how we can solve this. The role of lab testing in clinical decision making. Lab medicine is essential in healthcare. Lab testing accounts for less than 5% healthcare costs in the US and Europe. A survey of 79 cardiologists and oncologists found that 75% of patients underwent lab testing, and lab results contribute to 50% of clinical decision making. And you know how important they had this. If this is information coming from the cardiologist, I think it's very important. And last but not the least, when you reach out to us to figure out the results, there's a lot of things that we are thinking about. Because there's a lot of variables that surround this test. Is it the reference range? Is it contaminated? Was it transported under the right temperature? Did they test using the right tube? Was the reference range collected for this patient population? Because sometimes you find a patient population where, let's say the creatinine of people who live back here is so high compared to the people back there. I don't know what's going on there. We've seen those kind of data. So are they even using the right reference ranges? Is it a communication issue? Were there some trends that we missed? Are they looking at one data point instead of more? I think this is the end of my presentation. At this point, I would like to take questions.
I just want to say that you really did a great job with the presentation. And like you said, most of our clinical decisions come from the data the results that we get from lab testing. So it's really a good opportunity for me to kind of revise in my head that I have to pay attention to some of the co-founders that come with lab testing. Thanks, I appreciate it.
I will ask the next one. So my background, I did pathology, before maybe doing oncology. And this has always been one of the things I reflected about, how much clinicians trust results from the lab without actually knowing how it's done. So I think this is an excellent presentation in terms of even preserving. There's a question I usually ask, a famous question. A glucose done on a CBC, on a BMP or a CMP, is it as accurate as the one done on the glucometer, which is more accurate? If you understand the methodology, you'll be able to answer the question. So there are a lot of things behind it. Maybe now as an oncologist, I question a lot of pathology reports because I know how it's done. But a lot of people take it like exact science, which is not close to anything being exact. So where I work, everyone who comes for a diagnosis of sarcoma gets a second opinion. And that second opinion is always different because I know there are more than 200 types of sarcomas. Maybe others don't know that, or even oncologists, but it's certain things that reflecting about what comes out from the lab, the levels of errors, especially in A1C, if you even understand the concept and how difficult it was to do the test for A1C when it was created. The steps that involve doing an A1C, you will not just look at an A1C and say, oh, yeah, A1C, because it's not an easy test to do. Maybe methodology has changed since I left the lab, but that is an example of really understanding that the lab, as much as a clinician, the lab is not an exact science. Things change, conditions, you need to take into consideration conditions. So mine was just like a comment, because it's a background which I did back home in Cameroon. So, any questions?
Yes, thank you for that very insightful presentation. I wanted to ask, because you mentioned if you call a lab and you request for the lab director, you might get a bachelor's level lab director. And I want to assume that most times that's going to be the people who are around and are present. How often or how likely is it that one would be able to get a lab director, you know, of your education and your experience, and how well do you guys typically interact with the other lab directors or the other people in the lab to be able to transmit information if a clinician calls with a question?
So the way our schedule goes, for example, I am not in the lab every day, but I'm available on my phone every second. So when this comes, they notify me that someone has a question, and they'll redirect the person to me, and it comes over to me. So you also made mention of, so it's just to tell them you want that doctoral level lab director. And then you made mention of how we communicate with the people in the lab. We also have in-service and other things with them, but there was some time I made extra effort to educate the phlebotomists because I realized that they're the front end of the lab. And I was also trying to do it with the phlebotomists who had 16 plus years of experience. But it turned out that those are the ones that knew nothing. Like, I could not even tell them anything. Where they left 16 years ago, that's where they are. I had to get these people who just came from school too. I thought with all of the experience, they've seen the mistakes and they'll be able to go on, but it wasn't as easy. You know, I found it so difficult just communicating with them and telling them why they need to, when they see this test in the list, they need to give it this preference because of this. That because part is what they will not get. So I think that it's like, again, making sure that they have the right continuing education. Based on the rules that we come, if you have a phlebotomist who is educating patients or telling them, preparing them, they should have continuing education that enables them to know how to prepare the patients. Just being a phlebotomist isn't enough.
Okay, we'll have 3 rapid fire questions just around here, and then you can review.
Great presentation, thank you. Besides methodology, how does race affect the results, and how is the clinician made aware of the effect of the race on the results?
That is a very good question. Again, when I look at the requisitions, if there's a race component to it, that stays on the requisition. It doesn't go on the instruments. So it's like the clinician knows that this is race, right? sometimes it's research-based, it's information that we have within the lab, that is not privy to the clinicians. Again, that is that bridge. You had lab to doctors. It's that bridge that I thought something was missing. When they validate this test, sometimes we don't have enough of every race to collect the reference ranges. And so the reference ranges may not even be representing your race, because you have 5% of that reference on the data that was collected. But then that's the information that is used to treat the patient.
Just to add before that, most data we use in pathology, both clinical and anatomic pathology, were done on occasions. So that's the first part. Not all data is affected by race, but it's something we need a lot of data and in order to validate. So it's really going to be an area of research and an area where clinicians should take note of.
Thank you so much for your amazing presentation. Right now I'm sitting here as an intensivist and I'm nervous that I have had people make life and death decisions based on labs. Now I'm like, how many people have I sent to the funeral home because of that? But my question is there like a website or something that we can go to look up if we're doubting the result of a certain thing and we're like, wait a minute, is this patient taking certain things? Is there some kind of a resource out there where we can quickly go and look at the various common things, like you mentioned vitamin C, those common everyday things, turmeric, that can affect our various lab tests?
Thanks, Dr. Ayutakia. Thank you so much. You see, when I came up with lab to doctors, it's because I realized that there was no place that had information that I know that the clinicians needed. This is, again, I said I have nothing to disclose. This is not selling lab to doctors to you all. It's just to tell you that the one place I know that we constantly are updating it is the lab to doctors platform.
All the speakers, your presentation was not only funny, but really on point. So I enjoyed it. Just to piggyback off what Dr. Ayutakia said, my brain is kind of solution-oriented. We identify the problem, that there could be issues. What I'm trying to be clear about is the solutions. It's gonna be impossible, challenging, for us to have to call and ask for a PhD level lab person to solve a problem. We are laughing here, none of us will do it, right? We're going to, maybe we do it 1 or 2 times and then after that it's done. So we're still going to send more people to their graves, like she's saying, with unknowingly. So what is the practical solution? Because if you're telling us that an in-service, you try to do in-service with bachelor's level and all of that, it's not a solution. What then are you putting on the table that is a real solution to really help us help the patients? It cannot be only a PhD level, because that is taking out or eliminating completely another workforce, which is what we don't want to do. But what else can we do in addition to the in-service that hasn't been working? What can you tell us to help us so we can go back and also help our practices and things like that? Thank you.
Thanks for that question. I thought of this when I was creating lab to doctors. Where's the time to go looking, talking to people when you have that patient sick in front of you, right? And I thought that with the digital technology age, it's high time there's something created that you can just enter information and submit and see what are interference. So that's something that is that I and a team of laboratorians are working on. But besides, we've also come up with lab-focused continuing education for non-laboratory healthcare professionals. So if you can have your teams I know we all need continuing education credits by the end of the year. If they can get some of these continuing education credits, they would be on their way to being better and not even having to look for that doctorate level lab director.
Thanks so much for your talk. I have a question. Going back to the interactions that you showed between supplements and somehow it interferes with some of the labs, I want to ask if there's any ongoing work that's specifically focused on supplements that are found, not really supplements, but things that are common, say for instance in the African environment, that have profound potential to interact. Take the example of kola nut and bitter cola. Those two have over 1,000 chemical components, very complex. There are actually chemists who have studied the composition of bitter cola, studied the composition of kola nut. And I can assure you they probably interact with a lot of these assays. Yet, you know, we're using lots of testing that's bought from tests developed, say for instance, in the US and in Europe, and we use those in Cameroon. So is there any ongoing work to characterize the many things that people in the African environment consume on a regular basis and seeing how that interacts with their lab tests that we use in that environment? Thank you.
Yeah, I thought of that question when I got through with my residency, and I located a Cameroonian who was a professor in one university, and he went to Cameroon precisely to the Northwest Province. Then he was going to gather all the leaves and everything from some native doctor and bring to the US. When he came back to the US, I reached out to him. I'm like, have you started putting them on the mass spec? He said no. So I'm not followed up with him, but I think it's something that needs to be done.
Okay, so we are.
Okay, thank you for that very awesome presentation. A hand of applause, please, for Dr. Boma. I'm sure this will definitely help some of us in changing our clinical practice, or at least questioning some results that seem quite off the hook. So, Dr. Boma, in appreciation for your time and presentation here at ACPA 2026 conference, we want to say thank you. So we're going to have our other trainees come from the other session and join us to move forward.
Sure. What's the number?
careful. You're on TV.
Please, can we open that door? It's locked. The door, please. That door to open it. Yes. Here we go. when we go back, or when we're able to meet with other institutions, that we can leverage our collective power as an organization. So this is a lot of planning to be able to get it done. I would say at least a year plus to be able to have the roadmap with, some hiccups along the way, not to disclose everything here, but we do feel though that the end of it was the best thing that could happen to ACPA. So although we met some hiccups along the way that we thought could deter us, but in everything, if the right planning, the right objective, we hope to achieve the right goal, and I think we did it. So my goal here is to be able to talk to you guys about what we spent the money to do, and you'll be able to see as one of the other panelists do the presentations what we did with that. I would say that we were able to do awesome and stay under budget. So initially the board approved $20,000 for the project in Cameroon, and we were also fortunate that between the time we went to Cameroon, Goshen Medical Center donated $3,000, and obviously that also donated $5,000. And those donations were earmarked for this specific project. So that was a total of $28,000 that ACPA allocated for this mission. Every member that went to Cameroon paid for your flight. So I just want to thank the 7 people that took time away from their work and in addition to your finances to pay for their flight. But ACPA, on the other hand, was able to help with some accommodations. So the lodging for the time that we spent in Cameroon, ACPA assisted in paying for that. The meals, transportation. As you all know, we have 4-day seminar, and each day we had to provide meals for the attendees, and you get to find out as we talk about Cameroon, the things that you need to do to entice them to come and learn. So we covered the meals for the participants at the conference. We paid for publicity, transportation, photography, decorations, the ancillary support staff, and there were a lot of them. Because this mission was within 3 different facilities happening simultaneously. So we had the education center at the University of Boya. At the same time, we were carrying out the clinical screening at the Regional Hospital Boya. And at the same time, clinical screening was also happening at Claire Radiology at my 17. So for the entire 4 days, these 3 facilities were running simultaneously. So that was a really great accomplishment, the efficiency and the fact that we were able to get all those accomplished in 4 days. So ACPA did pay for that. Now the bulk of the money went towards paying for the actual test that we did do. So we did focus on cervical breast cancer, cervical cancer, prostate, and colorectal cancer.
wasting suture, right? In my, Western way, one suture is it, right? But I had to learn that. So I think that for me, the main takeaway is that, it's not a skill transfer. It's not, teaching. It's, a skill exchange, right? We have to go in. We have willing people, we have skilled people, we just need to work on exchanging skills. So another part of the clinical part that we did that we were really proud of, and thanks to Dr. Kenedy Foyo, who was not here, was breast biopsy simulation, which the radiologist and medical student and resident appreciated much. Because again, when we think about breast cancer in Cameroon and the population that we have, maybe we need to start thinking creatively, right? Maybe it's not the mammogram, which costs 70,000 francs that we need. Maybe we need to incorporate guidelines, which some other African countries are doing, which include ultrasound point of care testing. So I think that's that, right? And then, so thank you.
So for the sake of time, I think the campaign scope was 4 days of intense screening campaign. That's what we did with the population. We did a lot of screening. And as Dr. Factory had said, and Dr. Lee, the sites were Boya Regional Hospital, Clare Radiology, and we had partnership for long-term follow-up. And we did choose these cancers because those were the most prevalent cancers in Cameroon. And those are the cancers that are preventable, and we can have an impact on them. So overall, we did a total of 1,731 screening. This is not updated data. This is the data we had when we left Cameroon, because screening continued some few days after. We did 383 mammograms, where our target was 400. I think Clare Radiology had to get to 400. Cervical cancer screening, 591. PSAs, we did 278, and FOBTs, we did 479. You would see the results here. So this just showing our target based on target and what we did. But for now, we already have the 400 mammograms done, so that we could reach. That was the most expensive among all the tests we did. And Clare Radiology did 130. They are a private hospital, private diagnostic center that had been doing mammograms more than the regional hospital. We had to use them and their algorithm to train the regional hospital on how to do it, but they are very good at learning. So they got very quick at it, and they were rolling. So they were rolling. So this is very important. We achieved a 96% achievement rate before we left. Cervical cancer screening, because of the GYN program and the residency program back home, we were targeting 200. They went above the limit. They did 591. So this is also because, and we budgeted for 200. This was all done free. So we are very grateful. You can see how training physicians and auxiliary staff about the procedure makes them faster. They had done this before with the president visit and other visits. So this is one screening that really went well. We did prostate cancer as usual. Men don't turn out. It's not a problem where we had available tests for everyone to do. Men just did not turn out for PSA. So yeah, the men did not turn out for PSA. This is not a new problem. So here we did achieve our goal, but the turnout was a little bit shy for men. And here you can see the screening and the planned results and the targets. We exceeded our targets for everything except for the PSA. So here you can see positive results. We did have a positive PSA result of almost 25.6%, FOBT of 17.9%, cervical cancer of 16.9%, and for the mammograms, they were still being read. We had issues. This is a very serious discussion in Cameroon. We did go in to do mammograms. That for Clare Radiology was read because it's a private entity. We partnered. I've forgotten Dr. Mataze was very instrumental in also partnering with us and subsidizing these things that were done at Clare Radiology. And his results have been read. We do have reading results now that we're done at the regional hospital. there is a whole discussion around the radiologists don't think it's their job to read 400 mammograms without incentives, because that's not what they do every day. And the hospital feels that's part of their job description to read these things. So we went in with a campaign, and you can see a lot of these problems. You can go into some of the problem and then you create other ones. So our takeaways really from this aspect was high screening yields, and we exceeded our targets for some, and others we did not. Strong participation from the community, and there is just a high burden on met needs that we can help. We can partner. I always use the word partner. There's a lot going on in Cameroon. Don't underestimate what's going on. It's just directions, and you're going to learn a lot. So our next steps is, this is really very important. I know a lot of people will be asking, what is Acpa Medical Mission going to do? We actually want to also thank the Medical Council for helping us and facilitating us getting our, because you have to do things right according to how it's supposed to be done in Cameroon. So we had to get licenses, which were temporary licenses, to be able to practice, and we also had to show that we're able to have so we're planning on expanding screening capacity in Boya still. A lot of people ask me why Boya. We want to create a pool of excellence, then we can expand it, strengthen diagnostic and follow-up, develop sustainable annual programs, which we are doing already with the Ministry of Public Health, and we need a lot of your help. We need the GI's help when we finish. We need the gynecologists to review what we're going to send to them. They will not take it as, they would run it through the gynecology associations and all of that in Cameroon. We just want to start this process and make sure that there are times something is just the initials to start it. Once you start it, people will run away with your idea. So we don't want to claim that we are the ones trying to deal with it. We just want to initiate these screening protocols that are going to be validated locally, and we'll have guidelines in this field. Engage the ministry and global partners, especially the ministry. They were very engaged. We had more than a whole day of discussion with the Permanent Secretary of Cancer Committee in Cameroon. She was there, and she had a whole day of engagement with us, and she's waiting. She gave us assignments that we are hoping to deliver. So our outcome, so here is just highlighting our different partners. We're also we're going to work on signing a memorandum of understanding with the University of Boya, a memorandum of understanding with Boya Regional Hospital, and we cannot, how was this even possible? A lot of people ask this question, how is this possible? You have to, you know, what you know is important. Someone told me that, well, who you know is more important. So at least we have the president of the council here. Cameroon is one of those places that you need to understand the politics of who has power. So in all of what we did, we had a relationship with the minister who was very helpful. We also, and he gave us his go-ahead and instructed everyone to align with our policies. We made certain errors. We made certain errors. We didn't contact the delegate in time, but the delegate was very helpful when he got instruction from the minister. The governor was also very instrumental. You can't go to a region and do things without letting the governor know. So the governor, we had a reception from the governor. The vice chancellor was there from day one, with the help of the dean for the Faculty of Medicine, Professor Hale, who was very engaged in this process. So it became a bigger feat than we could ever imagine. Because we could not just march there was so much protocol. From CRTV to protocol, we had to change flyers 10 times because who stands on the right, who's on the left. So you should know these things will happen in Cameroon, because when we went in, we thought we were going for something very small. It was bigger than we thought. There was a very important statement made by the governor. He said he thought everyone in the US doesn't really want to support, because of the Anglophone issues that we don't politically hear, but he felt very, what word will I use? He felt touched and felt that through diaspora. And he feels that this is a message the president needs to hear. That's what he said. So,
Thank you, Dr. Muno. You've transmitted. You're amazing.
This one analysis of how we're going to move going forward. We do have next steps, and really, I will not waste a lot of time, but we need to continue what we're doing. As Acpa members, we don't need to parachute back home and just do things and leave. Others have done that before us. We need something sustainable. The question becomes, can we keep financing this from Acpa's pockets? I don't think so. But that's going to be a question I think others will ask. Should Acpa keep financing this project going forward? Can we have other partners which we are going to collaborate with? Are we just going to be concentrating on oncology? The answer is no. We're going to build on this and try to incorporate every specialty sitting here in our medical collaboration. I'm not calling it a mission. I'm calling it because it's a collaboration with our partners back at home who are as knowledgeable as us but may not have the resources or may not have the guidelines that we have and may not have the structure. And we will learn in return once we go to do this project. So there are several things that we are going to do. These are the different things highlighted here. And here is a short message. I don't know how much time we have.
Dr. Mukake. We need Dr. Mukake on.
No. So this is Dr. Mukake, who is the director of the regional hospital.
We don't have the volume.
Yeah.
Okay.
So I would. That's an amazing. He's just giving a testimony of how much the influence Acpa has had. Yes, we'll send it on the group chat.
Avi, is there a way to get that video?
So while we move forward, I just want everyone, it's a shared vision that Acpa has, that while we're going to achieve our goals here in the United States, where we are not going to forget where we come from. We are going to go back home. Maybe we have other partners that the president is working on, where we're going to engage the cardiologists here, the cardiothoracic surgeons. We're going to engage we thought the most needed were the primary care. Cameroon does something very unique. We train a lot of subspecialties without the internists. We need a lot of internists here to really go back and put things together. So we found out that everyone will be helpful. There were many Benzine people who needed Dr. Mbu and the others who, if they were there. So there was so much that can be done. But we need a structured medical mission where we can incorporate everyone in the future and try to bring as much change as possible. So while we wait on the video, any questions? Yes, please.
So for all the positives that you had, what was the plan for those patients?
Oh, good. Yeah, so that's a very important question. The Medical Council, first of all, made us have doctors that would follow up, but we had that in the past. We decided to do this in the regional hospital because it's an infrastructure already where you have most of the specialists. So we had guidelines even in the screening, what was going to be next. Those who were positive of FOBTs, based on the risk stratification, they were either sent for them to get colonoscopies. So we had a GI doctor locally who was part of our team, who was involved and who does colonoscopies. So we have colonoscopies being done in Mutengene and in Douala. So we had follow-up. Those who were positive for PSA, was a screening test, got quantitative PSAs that were followed up and linked to the urologist in the regional hospital. Those who had positive breast cancer, those who had positive mammograms, had re-evaluation and the plans for biopsy and further evaluation. The gynae team is very skilled back home. Gynes and obstetric is something back home that there's a lot of them. So they already, the partnership with University of Arizona, they do this all the time. They also do the cervical cancer screening, so they have a pathway, a referral pathway. Yeah, so we had, this was not, that's why we didn't build it in the community. We kind of did a community diagnostic, but in the hospital, so that the hospital takes ownership. And all of this planning was done with the director of the regional hospital and all the partners that were involved fully. Anyone has something to add? Yes.
Just the video.
Just wanted to add that we also have created a multidisciplinary group to follow up on all of the positive patients. So with the team locally and all of us.
I'm Dr. Martin Mokake. I'm a surgeon at the Regional Hospital Goya, the director of the hospital. I want to thank Acpa very, very much for the wonderful program we had recently. It was an eye-opener. It was one of its kind. It was the beginning of many, many good things to come. The collaboration both with the hospital and with the university has been very, very much epic. The screening is the biggest, the largest, and the greatest multi-site screenings that we've ever seen for a couple of years out here in Goya. So we are very grateful. A lot of people benefited from the prostate, from the cervical, from the breast, and from the colorectal screening. And right up till today, we are still following up some of those patients who came in for the screening. We want to thank you because this screening has gone a long way to reveal certain things that we did not even know existed within our community. The data that we are getting from this screening has been very, very rich. And we are grateful again that this screening was completely free of charge for every single thing that was done for these clients, for the population. It was free of charge. And it brought people from far away, from Bamenda, from Manfe, from Acpa, from everywhere to go here for the screening. And even right now, we still have spillovers and people are asking, when next are we going to have this? The program was not only rich at the hospital, it was also very, very enticing at the university. An exchange of ideas and current practices in surgery and in gynecology. It was wonderful. I want to thank Acpa very, very much for this. And I pray that we are going to continue to have this and make it something like a regular. It has been wonderful. And we can only say thank you and may God bless you all. And we are hoping to see you again in the shortest possible time.
So I think for the sake of time, Dr. Beck. Yeah, for the sake of time, I think we're going to move on with the program. Thank you.
No, I'm just going to... do you have...
Take pictures. Take pictures, yeah, we don't miss.
So please join me again in giving a hand to our delegation. Yes, please. That's how you do community engagement. That's how you get everyone involved. All right, so just wanted to say thank you. Do we have anything to acknowledge the team? Yes, there you go. Thank you. What? Thank you. So Dr. F1AK. One more. Dr. Lee herself. Dr. Fatcher. And Dr. Bruno, congratulations. Thank you. Thank you so much. Thanks again. Thank you. Fantastic job. All right, so we are going to, just given the time, we are going to go ahead, myself and Dr. Wallace. Please welcome Dr. Eric Wallace, who is
the director of e-medicine and a lot of other hats at UAB. As you know, over the past few years, we've been working on the ACPA UAB telehealth initiative. We brought a number of slides. We are not going to go into them. But I'm going to go ahead and give Dr. Wallace the first one just to provide a brief update on where we are with the telehealth initiative. And then we'll open it up maybe for a little bit of discussion. We hope to do this 5-10 minutes and we're done. And then there will be a lot of updates to the entire group because there are some things we need to do and need your help in terms of social media outreach to make sure people actually know that the telehealth initiative is going on. So thank you.
And once again, just really excited to be here and speak with all of you again and really tell you about the progress that we've made. So for those of you who don't know, we've been engaged in a project for interprofessional e-consult. So this is where one physician in Cameroon can actually consult with a physician in the United States if the need arises. So we spent a lot of time actually creating the platform. And so that platform was a collaboration between us, the Acpa here. So we presented the platform, we got feedback on the platform and improved upon it, and then we actually got feedback from doctors in Cameroon and then improved upon our platform, and only recently did we actually launch the platform. So it's a collaboration, it's hosted at UAB. It is free of charge. We have 2 years of funding to get this project off the ground. So free of charge for Acpa, and then free of charge to actually deliver these consults back to Cameroon. So we have had one consultation, and so it can work. I think that's what I always tell people when we're planning telehealth projects, is that the plan is not to plan for 5,000 of them. It's to get enough infrastructure to do one, right? And once you do one, you learn from it, and then you do second, third, fourth, etc. So we have done one. There's a lot of learning that happened from it. The first thing was that the information provided from a question perspective could have been better. So we need to, the scanned documents that came in, there could have been more, right? We always want more information. And same with the response back. We could have been better on the response back. So now we take that information and we learn from it and we say, how can we get better? Another learning, so we are now going hospital by hospital and making sure people know about it, because whenever you do a technology project, you actually have to get people to do the first one, right? So that's key, is how do I get people to get the activation energy to do the first one? We have learned that people are getting some information or some consultative care, just like we do in the United States. When we want a consultation, first thing we do is call our buddy, right? So we do a text message to our buddy. Completely and totally, we know who we trust to get that information. That's happening in Cameroon as well through WhatsApp, right? But despite the fact we can do this in the United States and do our text messages, we still have developed a process for interprofessional e-consults. Why? Because we get better information. We get targeted information, and then we have a documented response that we can go back to, right? So I think one of our hurdles is how do we differentiate the platform from a WhatsApp, just a text message to friends. The other thing is making sure that we understand that the quality of the consult going out is better than the quality of the consult from a group of providers that you may or may not know on WhatsApp. So these are some of the learnings that we've had, but it's always a collaboration. The other thing is that it may not be the thing that is needed. So this is a pilot, right? So if at the end of the day we say, look, a direct consultation is not moving the dial for patient care, what we need to do is learn from it and say, well, what is needed? So we just heard from the surgeons that this is an exchange of skills. So there's another platform called Project Echo, where it is truly a case-based, de-identified learning scenario as opposed to direct patient care. So there's lots of different avenues, but I think if we don't move forward, we'll never learn from it. And we won't learn what worked and what didn't work. So the fact that we have done one, everybody should be incredibly, who's been participating in the project should be incredibly happy with that. but now it's how do we move it one step further. So it's always about ratcheting. One final word in having heard the discussion about 1/3 of providers that may not want to do or have considered stopping clinical medicine, right? As somebody who is responsible for AI, and somebody who absolutely loves medicine, you know, back when I was 18 and even now at the same amount, invest in yourself and look at ambient listening. So you have to, like, this is something that can, I think it's kind of the spark that's back in medicine. You know, a lot of us don't like doing notes. Ambient listening takes that out and truly brings the joy back to medicine. So anyway, this technology project was born out of one of those things that was very annoying for doctors and was taking the joy out of medicine, which is, when it started at UAB, it's we could not get rheumatology consults. So rheumatology was actually having too many consults that they didn't need to be seen in person. The primary care docs could not get the information they need. Ergo, interprofessional e-consults was born, and now we use thousands of them a year to get care to people that need it. So just this is a part of it. If it is the answer, great, we'll see uptake. If it's not, then we pivot and we say what is going to move the dial, because at the end of the day, it's about getting care to patients that need it.
All right, so thank you, Eric. I just wanted to answer a few questions and then open it up to get maybe 2 or 3 questions if there are. Before I do that, I want to acknowledge all the members of the ACPA Telehealth Working Group who are in the house. Instead of calling names, may I ask us to stand up, because this is a total initiative. There is a WhatsApp group where we all respond to different things. Dr. Joe is not here, but has been a major champion, and this week has been on 2 meetings, telehealth meetings that we've had with the Cameroon team. So may I ask those on the telehealth working group to just please stand up? So why these hospitals? I think some of these hospitals, especially the Baptist ones, are places where we already have long-standing relationships and staff available to help with some of the uploading. So the uplift there was very low. And then you know, talking to other partners for the same reason as the cancer outreach, and giving our general expression here, for the most part, practicing in English, went with those places where there is great room for, once the pilot is done, to expand. The other thing that we feel, we had a meeting with all the doctors of the regional hospital in Bamenda with there, and it's very important to get the word out. So one of the things we want to do is to, if you look at this, the image out there is to work and put this out on WhatsApp groups, social media, etc., so people know that this is there. But we may want to also copy what has been done with the Cancer Initiative and have a formal launching of this, and I'm curious to hear what others think. That is the platform. We're not going. Just again want to thank all the ACP members. The names are not on here, but these are the specialties that have enrolled in this, and if you've not registered, this is your opportunity to scan that code and indicate your willingness to be part of this, because I do think, once we smoothen this all out and things begin to pick up, we may have a lot of need for more people to help with this process. So please, I'll come back to this if, yes, we will do that on the forum as well. We'll do it again. All right. And then, again, this just outlines what happened over this period of time and people who got trained and all of that. And so this will go out together with some supporting information. These are some of the questions that we had put together. That question about WhatsApp groups, how does this, what is the advantage of this over WhatsApp groups? That we need to expand awareness and engagement. And then in Cameroon, they asked, what about including Cameroon specialists as part of this platform, and that's a discussion that we can have? And then also, is there an opportunity to request for an individual consultant to provide a second opinion? So these are some of the questions we got from the folks out in Cameroon. And we will share this. There is being launched what is called GAIN, which is a global health AI collaborative platform that will bring together thousands of people to collaborate in this area. Physicians, trainees, etc. can have different themes to work on. So I'm going to pause there and see whether there are one or two questions. You can scan, and we'll go on from there. So thank you for your attention.
Thank you very much for this opportunity. Mine is not really a question, it's a suggestion.
Yes.
I'd like to find out if there's a way for us to also educate those who are offering their services on this platform on our end. Okay? Because the tendency, what I've noticed, is that when we speak to other physicians and healthcare workers in Cameroon, we tend to come from the mindset that we are better, we know more. I assure you, there are some bad boys and girls in Cameroon. They know medicine. So we cannot afford to go out there and be condescending because there are people asking for a consult. The fact that they do not have resources that we do have does not make us better than we are. So there should be some education on this side so that we know how to interact with them. And it's human nature too. It's also human nature. We need to know how to speak to people and how to share information as collaborators as opposed to with people from the diaspora who know better than we do. And I cannot believe that you don't have this. I don't believe that you don't have that. How is this possible? Things that you say here and there can be annoying to them and they will not be receptive. And the person that doesn't benefit from it is the patient. So think about the patient every time you speak to another physician in Cameroon. It's not about you or what you know. Just bring what you have in mind so we can help the patient. Just to comment.
To that, one of the reasons why this was how we started, but you're right, we need to educate. But it is important to know that one of the reasons we started with a second opinion, because there are groups that are going direct to the patient. And so then it would be a United States physician, as example, bypassing a Cameroonian physician and just saying, hey, you should have these thousands of dollars of drugs that we have in the United States. And it doesn't help anybody. So we definitely thought that there should be at least one layer between the patient, which has the cultural and healthcare context to take whatever recommendations we have and interpret it in the context of the scenario. But I agree, this is not to be condescending. It's really to say, look, we have a rheumatology specialist. This is a rheumatology question. What approaches could you take? But 100%, we need to educate.
Just a quick story that will say 110% why I agree with you that this education is important, and thank you for doing it because you just did it. A Cameroon-based initiative that uses mobile phone, all based in Cameroon. You had frontline workers and you had experts who were supposed to be the consultants in Cameroon, and it really picked up, and then the utilization dropped. And when we started troubleshooting it, all collaborated as a team, realized that the frontline workers felt like they were being bullied and scolded for not knowing things by the experts, which is exactly what is not supposed to happen. So I hope we don't get there, and I don't think we will get there. We all know how things understand how things operate in Cameroon and can take that into consideration. Thank you.
So I very much appreciate this opportunity, and I already signed up for anyone consultant. But really, my main question has always been: is there a way that we're working on standardizing the consults? Like, for example, maybe for internal medicine, you could have, this patient has blood pressure or blah blah blah. But like I'm in oncology, we are very, very detailed, very specialized, and we make very specific recommendations based on subtypes, right? So like, making sure that when ultimately I'm a breast medical college, if I get a consult, for instance, do I have everything I need to make a decision? Or it's going to be, oh, like they do in Cameroon, like they treat blanket treatment of breast cancer. Like we don't, like that's just not, it's just, yeah, like what the standard of practice that I've been working on some kind of standards by specialty. I did there, oncology, and very much in breast oncology is very, like, niche, and we have algorithms, that's about mine. And we're working on making sure that consult that come through, at least in oncology, and other specialty, I'm sure they have very specific requirements. And this, we're meeting some standards so that we're at this, as helpful as we can be.
Now that is phenomenal feedback. And it's the beauty of having a partnership, because we can actually take that and we can build it into the system. The real reason why we haven't gone there yet is we didn't even know the types of questions that were going to come. So what we wanted to do is decrease that energy of activation for the Cameroonian physicians so they could come and we could learn from what questions they're asking, and then we could put into place, well, what types of standards do we need? For instance, what are the required documentation to be uploaded for certain things? Well, one of the questions, what do they have, right? And that's learning for me as well. What is the standard of care there? And so, interestingly enough, UAB is involved in an AI project where they actually take the cancer guidelines by the country, because our guidelines are different than guidelines for India's example. So I think this is why we learn together, as opposed to what a lot of people do, say, here's my platform, use our platform. We have the ability to build this from scratch together and build it so it works for everybody. But I'll tell you right now, we do not have the right answer, right? So that will only be in collaboration with each country. The consultants here, the people requesting the consults, and the people building the platform. And that's why I'm excited about this project, and the hope is what we're developing is an approach to develop this not only for Cameroon, but for other countries, which is how do we address this, knowing that all countries are a little bit different, right? So it's really the process that we're developing for the development of global healthcare interprofessional consults, but I love the fact that we're all in the same room talking about it.
So we'll have to, let me know, yes.
Two questions, one quick one and then the other one a little bit longer. I'm curious to know, you said you received one consult already. What specialty was it? Just out of curiosity.
That was hematology.
Thank you. The second question is around the culture of consulting. That's not something that, I trained in Cameroon, that's not something that's built into the medical culture there. People do it informally, but it's not formalized in the way it is in the US system. So in building this, in developing this project, what is the work that you've done in that context with Cameroonian physicians in building that culture of consulting? And then the second question is, what are the needs? Has there been any baseline survey? Like, maybe the need for addiction psychiatry consults is not as high as the need for an infectious disease consult or a cardiology consult. So what is some of the work that has gone into that, into optimizing the rollout of this project? Thank you.
Yeah, so let me take that. So this started anecdotally based on people who had instances where, a second opinion would have been helpful. And then the whole concept was developed and shared with a number of people, and also shared and discussed with people and collaborators in Cameroon, about a year prior to this. And we have a WhatsApp group of my class out of Q's, and we shared that, and the reviews were always very positive on this side and on that side. We absolutely did this. And then when this was designed, also used them as a platform, and others who collaborate in other places on different projects presented it and got input from there. And then we also got input from the Acpa group, Dr. Raisa from this year. We had a number of meetings. There was a task force that worked on this even before it came out into the open. So years of work went into this. Initially, just a few things, like people were clear about things around cancer, things around cardiovascular. There were maybe two others. But at the end of the day, we thought, well, why not launch it as a pilot right, and see where the demand is, right? So there is still an opportunity to do a survey, and anyone who wants to be part of this, please, you're so welcome. But this process might help us identify some of the needs. And in fact, one of the questions we had from the Vanessa team was, what if we have something and you don't have the expert? And so we said, well, that might be the opportunity to reach out to the group and identify those experts to respond. But thank you for your question. And again, I was just so inspired by the last presentation of just how teamwork can carry things, and would like for us to be very engaged with this at this end. Everyone is welcome, but also even engage more in Cameroon.
Yeah, one last question, sorry.
No. I'm sorry.
One last question.
No.
No, it's very important, I think, Dr. Disha, is how do we give feedback to those who are back home? Are they able to tell if the consult was helpful or not?
Yes. So, and this, we offered that opportunity, right? And the initial feedback that came back wasn't very reflective of the feedback that Dr. D got on the spot in Cameroon. So I think we have to be more assertive when we, after each consult, especially early on, reaching back to the physician and saying, let us know either way if we can, do more. And the other thing, training item that we are thinking about is to let them know it's not a one time and it's done, right? You want to do as much as possible one time, but can this be a bi-directional thing where if you're not happy, answer a question? And I think the QI is on both ends. So more information coming into us will allow us to be able to provide more feedback, and then obviously we have to be more detailed, taking into consideration the circumstances in Cameroon, provide the full frame of things, but emphasize what the circumstances in Cameroon would be. And I think sometimes you'll be surprised by what they can do. So by not limiting ourselves, but providing the full spectrum, I think we allow them to decide what to do. Eric, you have the last word.
Oh no, just last word on your consulting. Consulting wasn't always the thing here in the United States either. My dad was part of a group, they trained for surgery or internal medicine, and it was considered weakness to consult. And now here we are, and he's retired, but we consult for everything, right? And so I think that this is our opportunity to see, one, is it needed, and does it actually move the dial? And we also have to be willing to accept, maybe it doesn't, maybe it's not right now, right? Or maybe we've started something that will move the dial. So that's why we wanted to lower the cost of activation, be ready. If it succeeds, great. If it fails, we learn from it. Either way, we have taken a step.
Thank you all.
Thank you again, Dr. Hello? Okay, please don't leave. Thank you again, Dr. Tita, Dr. Wallace, as always, for the work that you're continuing to do in Cameroon, because we know it's going to be multiple years down the road, but for each year that you're here, we want to appreciate your time. And so thank you again, Dr. Wallace. And Dr. Tita, thank you very much as well.
Thank you. I will just point out that he personally invested in this. So thank you.
Okay, we're going to move forward. I'll call on our immediate past president to introduce our next speaker.
Fellow ACPA delegates and conference attendees, it is my distinct pleasure to introduce to you a fellow colleague, a dear friend who has, since becoming the president of the Cameroon Medical Council, become a great partner to the ACPA. For those who remember, Dr. Fonkwa has done 2 town halls with the ACPA and has participated in an in-person visit, a session that was held in Maryland and attended by our president and our president-elect. Dr. Fonkwa, as you have heard, is the president of the Cameroon Medical Council. He is the founder and the CEO of Clinique Edimed in Douala. His specialty is in diabetic management, and he has been at the forefront of innovation, engagement, and transparency in the delivery of healthcare in Cameroon. Dr. Fonkwa is not shy about engaging the political and administrative folks in Cameroon about what needs to happen. He has been engaging all of our peers, our colleagues across the world. He travels to Europe, to North America, to Asia and other parts of Africa to make sure that the voice of our colleagues back at home, as you hear, that our voices are heard. Every time I speak with Dr. Fonkwa, I am reminded that there are people back at home who care about our profession. Ladies and gentlemen, we are distinctly lucky and thankful that Dr. Fonkwa took the time to come and visit us in the United States, and our president made sure that that happened. I remember talking to her a few months ago, and she said, whatever we do, we must make sure that Dr. Fonkwa attends ACP at 10 years old. Thank you, Dr. Fonkwa. Thank you, Dr. Mimi.
Bonsoir tout le monde.
Bonsoir.
À l'entame de mon propos, de mon exposé, je voulais vous dire que je suis particulièrement heureux d'être là. Ainsi, très chers consoeurs et confrères, mesdames et messieurs, c'est avec une émotion sincère et une joie très profonde que je prends la parole devant vous aujourd'hui. Je tiens avant tout à remercier le comité d'organisation, particulièrement la présidente Dr. Nindi,
Good evening, everyone. It's my pleasure and honor to be here and as the president of Cameroon Medical Council.
Je tiens donc avant tout à remercier le comité d'organisation, particulièrement sa présidente, le Dr. Nindi, de m'avoir convié à ce moment d'exception qui consacre le 10e anniversaire de Acpa.
I'd like to thank Dr. D, the president of the ACPA, for inviting me on this special occasion as we're celebrating 10 years of ACPA.
Ceci témoigne de votre solidarité exemplaire et de la force du lien qui vous unit malgré la distance du Cameroun.
This is a testimony of how strong this institution is and your commitment to invest in Cameroon, you know, despite the distance.
Être parmi vous ici est pour moi bien plus qu'une invitation, c'est un ressourcement.
Being here is more than just an invitation. It's an opportunity for me to, it's a resourceful opportunity for me.
En vous regardant, je vois le visage d'une médecine camerounaise rayonnante et universelle.
When I look at you, I see a radiant and opportunity for university, ways to engage in practicing medicine in a universal way.
Je suis venu vous dire ma fierté et partager avec vous une vision qui me tient particulièrement à cœur.
I'd like to share how proud I am, and I'd like to share a vision that's very dear to me.
Et quelle est cette vision? C'est celle de faire de notre pays, à plus ou moins brève échéance, une destination très prisée du tourisme médical. Et ça, avec vous.
My hope is to build a partnership so that we can build, like our country can become a destination for medical tourism.
Je suis ainsi convaincu que notre présence commune ici doit sceller la convergence de nos ambitions et une coopération fraternelle.
I hope we can build a partnership for long-term, goals and achievements.
Et cette coopération sera portée par cet altruisme qui définit notre vocation afin d'assurer ensemble l'avènement d'une médecine de qualité dans notre pays.
So this partnership will be built on altruism, which hopefully will foster high quality medical practice in Cameroon.
À présent, je vous invite donc à une réflexion sur les grands défis à relever pour redorer l'image fortement écornée de notre profession dans notre pays.
I invite you to a discussion that will be thought-bringing and hopefully, open door for collaboration and opportunities in the future in Cameroon.
Et voir quelle pourrait être votre place dans la solution à ce problème.
And we can hopefully see how we can partner and how you can contribute in finding solutions in Cameroon.
Nous allons rentrer dans le vif de notre exposé d'aujourd'hui. Et comme vous le constatez, depuis bientôt 20 ans, notre pays traverse une période de turbulence assez importante. Cette turbulence perdure donc depuis 20 ans. Elle est pernicieuse. Les causes sont multiples. Et malheureusement, il nous faut des solutions très urgentes pour pouvoir sortir de l'eau. Notre causerie portera essentiellement sur 2 points. Nous allons faire un état des lieux, c'est-à-dire savoir quelles sont les causes de la dégradation de notre profession. Nous apporterons quelques esquisses de solutions. On terminera par une conclusion, mais entre les deux, je vous parlerai de quelques réalisations de l'actuel Conseil de l'ordre. Alors, quel est l'état des lieux de la profession dans notre pays aujourd'hui? Nous avons recensé 5 causes à la dégradation de la profession. La première cause, c'est la formation des médecins. Celle-ci est particulièrement médiocre. Il y a quelques années, l'État a cru qu'il fallait augmenter de façon substantielle le nombre de médecins et a décidé de multiplier les facultés de médecine. Mais malheureusement, on a perdu de vue que ce qui était notre force, on ne l'a pas reproduit dans les nouvelles facultés. C'est-à-dire, nous avions à l'époque le CUS, qui était quand même la référence dans toute la région Afrique centrale. Au lieu de reproduire le CUS, on a créé des facultés en oubliant qu'il fallait des écoles d'application. Et effectivement, aujourd'hui, le produit est mauvais. D'autre part, on a créé des facultés sans tenir compte qu'il y a des normes recommandées, qu'il faille penser aux enseignants. Conséquence, on assiste à un vagabondage des enseignants qui parcourent le territoire d'une ville à l'autre. La deuxième cause, c'est le chômage paradoxal des jeunes médecins. Chaque année, nous formons environ 750 médecins dans nos facultés et nous viennent de dehors environ 200 à 250. C'est-à-dire chaque année, nous avons 1000 médecins qui sont formés, mais malheureusement, depuis 5 ans, l'État ne recrute plus. Et pourquoi est-ce que l'État ne recrute plus? Parce que le pays subit actuellement les fauches du Fonds monétaire international. Et depuis 5 ans, on ne recrute plus. Le privé consomme mal an, bon an, environ 150 à 200 médecins par an. Le reste, à la touche. Et pourtant, les besoins sont énormes. Vous savez très bien que l'OMS recommande environ 2,5 médecins pour 1000 habitants. Au Cameroun, nous sommes autour de 0,7 médecins pour 1000 habitants. Donc, les besoins sont énormes, mais on ne recrute pas. La troisième cause, c'est le salaire. Nous sommes les moins-disants de toute la région. Il y a un an, j'étais au Tchad. Le médecin tchadien gagne 400 000 francs par mois, alors que nous sommes autour de 200, 250 000. Évidemment, la conséquence de ce faible salaire, c'est la fuite des cerveaux si chèrement formés. Évidemment, le corollaire de tout ceci, c'est qu'aucun système de santé dans le monde ne peut prospérer ni survivre à la paupérisation, voire à la clochardisation de ces médecins, qui sont les acteurs majeurs, indispensables et incontournables de l'offre de soins. La quatrième cause, c'est la perte de confiance des populations en leur médecine. Évidemment, la population n'a plus confiance aux médecins. Conséquent, ceux qui ont les moyens se soignent à l'extérieur et ceux qui n'en ont pas ont recours aux solutions alternatives, c'est-à-dire la médecine de la rue, la phytothérapie, etc. La dernière cause, c'est l'exercice illégal de la médecine. Et là également, je vais vous surprendre un peu, au Cameroun coexiste une phagocytose, c'est-à-dire qu'il y a des gens qui n'ont rien à faire avec la médecine, qui viennent exercer de la médecine. Mais ce qui est curieux, c'est que depuis quelques années, nous constatons que la profession est rongée et détruite par les professionnels de la santé. C'est-à-dire que vous allez voir dans les quartiers des médecins qui créent des centres de santé, ils mettent des infirmiers. Au niveau du ministère, vous avez presque tous les directeurs qui ont soit des écoles de formation à travers le pays. Et ceci concourt effectivement à détruire totalement le tissu médical. Alors, quelles peuvent être les solutions? Nous les rangeons en deux. Il y a des solutions endogènes et des solutions exogènes. Quant aux solutions endogènes, nous pensons sincèrement que pour y parvenir, il faudrait des états généraux de la santé. Le mal est tellement profond que apporter des solutions cosmétiques serait très inefficace. Et ces solutions me semblent très urgentes et partout où nous passons, nous le signalons, on le propose, on en parle, on vous écoute, mais rien ne bouge. Parmi ces solutions, il y a la promotion d'une formation de qualité. Vous savez très bien que notre profession allie à la fois la théorie et la pratique. Donc, il faudrait adosser toutes les écoles de formation à un hôpital d'application. Qu'est-ce qu'il faut faire? Nous avons 10 facultés aujourd'hui. Il y a une seule qui a un hôpital d'application, c'est l'ancien CUS. Soit il faudra donc créer 9 centres de formation, ce qui coûte extrêmement cher, soit réduire à 2, et c'est ce que j'ai proposé au ministre de l'Enseignement supérieur. À Yaoundé, on a déjà un, on pourrait peut-être, dans une autre région du Cameroun, peut-être en zone anglophone, mettre un deuxième CHU et former de façon correcte et assez efficiente nos enfants. Il faudrait effectivement recruter et former massivement des enseignants. Et pour cela, il faudrait ouvrir grandement les portes au cycle de spécialisation. Or, aujourd'hui, il faut des concours très sélectifs pour pouvoir se spécialiser au Cameroun. La deuxième solution, il faudra instaurer un plan de carrière clairement défini et qui consacre le mérite. Aujourd'hui, nous constatons qu'il n'y a aucun plan de carrière. Vous pouvez former un enfant qui, au bout de quelques années, vient être votre chef. Ceci est drôlement frustrant et inadmissible. Je crois qu'on a une profession qui est un peu comme une profession militaire, c'est-à-dire qu'il y a des grades. Malheureusement, chez nous, il y a une formule que nos politiques aiment beaucoup. Le diplôme vous appartient, mais le grade ou bien, je ne sais pas, la fonction appartient à l'État. La troisième solution, c'est la revalorisation des salaires. Ça, vraiment, il faudrait le faire. Et vous constatez également qu'au pays, tous les médecins sont consacrés à Douala et à Yaoundé pour la simple raison que ce sont des zones assez rétributives. Dans l'arrière-pays, il n'y a personne. J'ai proposé jusqu'à la présidence qu'il faudrait, pour couvrir les déserts médicaux, octroyer des primes assez substantielles aux médecins qui y vont, par exemple des logements gratuits, l'électricité et même des véhicules. Ça, je l'ai vu dans les pays d'Afrique de l'Ouest, où pour combler ce genre de désert, il fallait inciter les gens à s'installer. La quatrième solution, il faudra créer des pôles d'excellence, aussi bien dans le secteur privé que dans le secteur public. Ceci permettrait effectivement de réduire les évacuations sanitaires qui nous coûtent extrêmement cher. Enfin, il faudra instaurer une lutte permanente sans merci contre l'exercice légal de la médecine. J'ai mené une petite enquête à Douala. Nous avons environ 1000 cas de centres de santé clandestins, rien que dans la ville de Douala. Et lorsqu'on étend sur l'ensemble du pays, si nous fermons tous ces centres, on peut résorber le chômage des jeunes confrères qui aujourd'hui cherchent de l'emploi. Et c'est un rapport que nous avons porté à la connaissance des autorités. Les solutions exogènes, elles sont de deux ordres. La coopération, elle peut être régionale, africaine, internationale, elle est très importante sur le plan de la formation, de la recherche et des échanges. Mais la vraie solution, c'est la diaspora. Encore un paradoxe que nous constatons, le Cameroun dispose d'une diaspora extraordinairement efficace, aussi bien en quantité qu'en nombre. Mais malheureusement, on ne la sent pas sur le terrain. Sur toute l'Afrique, c'est la diaspora qu'on voit très peu sur le terrain. J'ai essayé de me poser des questions. Pourquoi? Je crois qu'il y a eu des tentatives individuelles, parfois collectives, et je sais que vous avez été buté devant les portes fermées des autorités, et je reconnais que c'est assez décourageant. Et je suis là pour qu'on explore ensemble quelles sont les possibilités, qu'est-ce qu'il faut faire pour briser ces murs et vous inciter à venir nous donner un coup de main. Alors, quelles peuvent être les contributions de la diaspora? Elles sont nombreuses. En Europe, je l'ai vu, surtout pour le Maghreb, que lorsque un Maghrébin est chef de service quelque part en Europe, chaque année, ils font tout pour ouvrir des postes et recrutent leurs frères. Malheureusement, la communauté camerounaise brise par le contraire. Donc, on peut admettre des jeunes confrères en stage. On peut améliorer nos plateaux techniques. Ceci est important. On en reparlera tout à l'heure. Comment est-ce qu'on peut améliorer ces plateaux techniques? Le transfert des compétences et des connaissances en présentiel ou par télémédecine, je crois qu'on en a parlé tout à l'heure, notamment la téléexpertise, le téléenseignement et également les formations continues. Nous pourrions de façon substantielle réduire les évacuations sanitaires. Je peux vous affirmer que ces évacuations nous coûtent à peu près 1,5 fois le budget du Cameroun chaque année. C'est énorme. C'est de l'argent que nous perdons et qui aurait pu tourner dans le circuit médical. Ainsi, il faudra rendre notre médecine assez attractive et compétitive comme elle était il y a une trentaine d'années. Et évidemment, comme je vous l'ai dit à l'entame, faire de notre pays une destination de tourisme médical. En pratique, quelles sont les voies qui s'offrent à la diaspora? Il y a deux possibilités. Il y a les missions que vous faites déjà, de haut niveau, comme ce que vous venez de faire à Aboya. Mais je pense que ces missions, pour être pérennes et efficaces, devraient être payantes. J'ai appris que vous avez décaissé à peu près 20 000 $ pour cette mission. C'est enthousiasmant, mais il faut que ce soit payant. Je ne crois pas à la gratuité en matière de santé. Quand vous donnez gratuitement, ce n'est pas suffisamment apprécié, même la personne qui reçoit. Il faut une participation. Aussi modeste soit-elle. Donc moi je pense qu'il faudrait que les gens participent, que ça entretienne chez vous également un certain engouement. J'ai appris également que ceux qui ont participé à cette mission ont payé leur billet d'avion. Est-ce que vous serez prêts à le faire dans 6 mois, dans 2 mois? Je crois. Parce que ça coûte quand même cher. Et ensuite, le retour au bercail. Je vais peut-être faire une petite parenthèse. J'aime bien prendre cet exemple, c'est l'exemple indien qui nous parle. Il y a environ 30-40 ans, ils ont émigré massivement par ici et en Angleterre. Mais sauf qu'après 30-40 ans, ils sont revenus chez eux. J'avoue que certainement qu'il y avait une politique d'accueil. Mais aujourd'hui, l'Inde est devenue la première destination de tourisme médical dans le monde et nous le voyons. J'ai dit la diaspora camerounaise est capable de transformer la médecine camerounaise et d'en faire la première destination de tourisme médical. J'en suis persuadé. Je voudrais m'arrêter peut-être là sur ce sujet pour vous parler très rapidement de quelques réalisations de l'actuel Conseil. En 2 ans, nous avons digitalisé totalement la gestion administrative et financière de l'Ordre national des médecins du Cameroun. Tout à l'heure, nous pouvons faire un petit essai. Je vais vous donner peut-être le site. Vous allez entrer, vous pouvez vous balader dedans. Ceux qui ont un numéro de téléphone peuvent carrément se retrouver, consulter le tableau de l'ordre, peuvent payer leurs cotisations là dans la salle et ça génère immédiatement le reçu. Nous ne voulons plus manipuler de l'argent, c'est pour une question de transparence.
So I'd just like to let you know that the platform for the CMC has been fully digitalized, and today we can even do a hands-on session where you can actually try to register and pay your fees and generate a number?
Nous avons réalisé, comme je disais, pour la première fois, le tout premier tableau de l'Ordre national des médecins et que nous devons réviser chaque année au mois d'avril. Nous sommes aujourd'hui environ 14 000 médecins inscrits.
There are 14,000 physicians that are registered as of today.
Bon, nous avons créé une mutuelle des médecins. C'est une idée qui m'a beaucoup taraudé l'esprit. J'ai constaté qu'il y avait certains de nos confrères qui décédaient dans des conditions inadmissibles de paupérisation. Et je me suis imaginé que si on avait une mutuelle, surtout pour ceux qui sont jeunes, ça pourrait préparer une retraite, ça pourrait être servi également de retraite complémentaire. Ça fait exactement 5 mois que la mutuelle est créée et je vous assure qu'il y a un véritable engouement. Et je vous incite, vous qui êtes là, vous pouvez également vous y abonner. C'est très facile. La mutuelle est gérée par une assurance de réputation africaine. Ce n'est pas nous qui la gérons. Vous cotisez et vous voyez comment ça vous produit de l'argent. Le minimum est de 10 000 francs CFA par mois. Vous pouvez aller, c'est à taux variable. C'est vous qui fixez la date d'entrée, la date de sortie également.
There is a mutual fund that has been created and for the past 6 months, and it's managed by an insurance company. The minimum fees to pay is about 10,000 CFA, and this is the goal is to help physicians that are going through hardships, especially young physicians.
Toujours dans la quête de résoudre le problème qui me tient à cœur depuis que je suis là, c'est-à-dire le chômage des jeunes confrères, j'ai établi des conventions de financement avec des institutions bancaires qui peuvent accompagner les médecins qui veulent s'installer et même les seniors qui veulent s'équiper. Donc, ces banques nous offrent des crédits à des taux assez préférentiels. Si ça vous intéresse également, c'est pour ceux qui ont des projets d'investissement au Cameroun, ça peut vous aider également.
We're also partnering with some local banks to secure loans for people who want to invest, if that's something that's interesting to you.
Et nous avons également institué 2 grands prix. Il y a le premier prix, c'est la Golden Palm au NMC, qui consacre les 50 ans d'exercice de pratique médicale de certains médecins. À ce jour, nous avons 5 lauréats qui ont été consacrés. Vous verrez la photo de tout à l'heure. Et ensuite, le deuxième prix, c'est le prix Benfessal de l'altruisme médical. Vous verrez pourquoi nous l'avons institué. Voilà les 5 lauréats de la Golden Palm. Vous reconnaissez certains. Il y a le professeur Tétanier, le docteur Acpa, qui était de la CDC, actuellement retraité, le docteur Fozo Léon, psychiatre, Chissé Mathias, gynéco, et Edouard César, gynéco également. Et là, c'est le prix Benfessal de l'altruisme médical. Ce prix, c'est une histoire assez douloureuse. C'est un jeune confrère. Il est décédé il y a aujourd'hui 14 ans. Il n'avait travaillé que 2 ans. C'est un jeune qui, affecté à un poste à Poli, il trouve un hôpital complètement délabré. Il utilise son rappel de salaire pour équiper l'hôpital. Et le jour où il décède, il avait travaillé toute la journée. Il avait opéré. Et vers 1h du matin, il va se coucher et sera mordu par un serpent. malheureusement pour lui, il n'y avait pas de sérum contre ce type de serpent. Et il décède lors de son évacuation. Malheureusement, personne n'a jamais parlé de cet enfant. Donc, on s'est dit quand même que les hommes normaux devraient avoir un peu de la mémoire. Même dans la ville où il est décédé, personne, même pas le maire de la ville, n'a jamais honoré ce garçon. Et encore moins le ministère de la Santé. Vous avez son histoire sur le... Voilà. Voilà un peu une petite historique des anciens présidents de l'ordre. Vous reconnaissez le professeur René Isonga, qui a trôné pendant 30 ans. Mon grand ami, le feu Daniel Mouna, 11 ans, à qui nous devons notre siège. Et j'espère que vous connaissez un peu l'histoire de ce siège de Yaoundé. Dan a eu une opportunité, c'est une maison qui avait été saisie par une banque et qui la vendait, on le lui a proposé. Il a préféré financer de son argent pour nous prendre ce siège qui nous a coûté 100 millions à l'époque. Et même à sa mort, on n'avait pas remboursé, c'est nous qui avons remboursé bien après.
Using some sort of loan, but even by the time he died, the house had not been paid for.
Et Dr. Guy Saint-Jean, que vous connaissez, mon prédécesseur.
And Dr. Guy Saint-Jean, the president before me.
Bon, en conclusion, qu'est-ce qu'on peut dire? Nous pouvons dire que notre médecine est vraiment malade. C'était... Ah oui, ça, il faut le dire. Elle est malade. C'était la locomotive de la sous-région Afrique centrale. Aujourd'hui, elle est à la traîne. Seule une prise de conscience collective et des actions urgentes, fortes et efficaces, impliquant pouvoir public, médecins, population, diaspora, pourra inverser la tendance. Qu'attendent les pouvoirs publics? Il faudra qu'elle fasse la promotion d'une médecine de qualité. L'employabilité des jeunes doit être un service, une préoccupation de tous les jours. Il faudrait revaloriser les salaires, établir un plan de carrière clairement défini pour éviter le népotisme, le clientélisme, et il faudra lutter contre l'exercice légal de la médecine. Pour les médecins, ils doivent être bien formés, observant des règles d'éthique et de déontologie. Mais là également, je m'arrête un peu. Quand on a faim, on n'a pas le temps de penser à l'éthique et à la déontologie.
When we're hungry, we have no business dealing with ethics and deontology.
Les populations, elles doivent être bien informées du danger du consumérisme. Parce qu'aujourd'hui, nous assistons à quelque chose d'inédit. C'est les malades qui vous disent ce qu'il faut. C'est qui vous disent les examens à faire, les médicaments à prescrire. Donc, ça devient très très difficile d'être médecin. La diaspora, je suis là pour ça. Vous devez vous engager. Vous ne devez pas vous décourager. Il y a des pistes. On a besoin de vous. Il n'y a que vous pour porter notre médecine à un certain niveau. Il faudrait que vous en soyez conscients. J'aime souvent dire qu'un homme normal doit être animé par un double devoir de mémoire. Un devoir de reconnaissance, parce qu'on vient de quelque part, et un devoir de restitution. Parce qu'on a reçu de quelqu'un, il faut rendre. sur ce, je vous dis vraiment merci pour votre meilleure attention.
Thank you. Thank you, Dr. Fonqua, to mention nothing is free, because for somebody like me who, je vais parler en français. Oui, pour une personne comme moi qui a essayé des projets au pays, tout est bien quand ça sort de votre bouche personnelle. Là, la CATI, Canal 2 va même le ministère, ils seront très contents. Mais du moment où ça doit sortir de leur bouche, là, le projet va prendre des années et des années. Donc, merci vraiment de mentionner ce point. Et ce qui m'amène à mon deuxième point, qui est s'il y avait une seule solution, pour la maladie de la médecine au Cameroun, j'aimerais parler de l'implication du gouvernement. Tant que le gouvernement ne s'implique pas totalement et complètement à l'image de la médecine au Cameroun, ce serait vraiment trouver des solutions éphémères. Pourquoi? Parce que ce soit concernant les salaires, concernant même l'image de la diaspora, parce qu'il y a cette frustration. J'ai fait un stage au Cameroun, on va me dire, oh, je pense que parce que tu sors de l'extérieur, tu connais quoi et tout. Donc, tant que le gouvernement ne s'implique pas et tant qu'on n'accepte pas que cette réalité, l'une des solutions, toutes ces solutions-là, ne représentent rien, tant que le gouvernement ne s'implique pas, on aura vraiment des problèmes à s'appliquer à la maladie de la médecine. Merci.
Non, je suis là pour le dire. Il y a des pistes. Je crois que nous n'allons pas faire le procès du gouvernement, mais qu'est-ce que nous pouvons faire? Le privé peut parler au public. Vous n'avez pas besoin d'une autorisation pour travailler avec le public, avec le privé. Quand vous parlez d'excellence, nous pouvons imaginer que dans les grandes villes du pays, on choisit 2 ou 3 grandes cliniques dans chaque région, dans lesquelles vous pouvez venir travailler dans un premier temps. Et si ça excelle, ça va capter cet argent qui sort pour les évaluations sanitaires, parce que je vous assure qu'il y a des gens qui sont prêts à mettre de l'argent pour leur santé. Donc, ils ne sortent pas parce qu'ils veulent, chacun aimerait bien se soigner chez lui. Donc, si nous réussissons à mettre en place des pôles d'excellence, vous pouvez venir travailler very brief and straight to the point. I just wanted to emphasize the point that Dr. Kessa translated. Dr. Fonkwa is stating that he is willing to facilitate any specialist in America who wants to work with a private clinic in Kenya. Coming to specific work to make sure that they have access to the right registration. That's the commitment that is made. So I wanted to emphasize that. Yes, and you will be paid for your services. We will generate this service. Je voudrais également dire que je veux voir avec la présidente si ACP peut nous désigner quelqu'un qui représente l'ordre ici. Et comme ça, les dossiers d'inscription, je peux vous assurer que tout dossier complet aura une réponse en 60 jours.
I'd like to inform you that I'm trying to work with the and ACPA to have a representative of the Cameroon Medical Council here in America that can be in charge of the registration process within the CLC. And I can assure you that within 60 days, the person say salary is really government thing. The minimum wage, for example, is 40K, CFA Cameroon, as opposed to, like, for example, Malabo, it's 150K. So this really comes down to a policy issue, which we don't have control on.
Okay, so I think we want to thank the President of the National Medical Council. As you can see, we have a standing ovation. We're happy to have you here. So thank you.
In a segment a night.
Okay. Where's the mic? Okay, thank you, Dr. Fonko, again for that really eye-opening what is happening to our colleagues back home and how we can be of help. So this next team, this is one of the most important 30 minutes we're going to need to spend, and this is because we have to be able to shape how we move forward in this organization.